Good afternoon and welcome to this MedIQ Facebook Live event entitled Providers, Pandemics, and PTSD. Please secure your own mask first before helping others. My name is Mark Hakam and I'm Director of Risk Management and Patient Safety Education at MedIQ. Physicians and other healthcare providers continue fighting on the front line against the COVID-19 pandemic. There's been a lot of buzz in the media about protective equipment, about rapid testing, but far too little attention is being paid towards the mental health of our healthcare heroes. Many providers are now facing fatigue, fears, uncertainties, and ethical dilemmas that they were never prepared for. I'm joined today by Dr. Jessica Gould, Assistant Professor of Psychiatry at Washington University in St. Louis. She's with us today to help us understand the impact this pandemic is having on the psychological well-being of our healthcare workers. For those of you joining us live, we encourage you to post comments and send along your questions. We'll do our best to answer them. Dr. Gould, thank you so much for joining us today. Can you tell us a little bit about yourself, your practice, and your professional interests?
Sure. Thanks for having me. I split my time clinically between the College Mental Health Center and where I see college students and graduate students, and a just generic outpatient clinic where I have preference for transitional age patients, so it's like 18 to 34, or also see healthcare professionals as patients. And my research interests are often, again, healthcare professionals, stigma, the media influence on mental health. And I am a freelance writer and I write often about the media influence on mental health. You can find me on social media talking about the same thing. I'm really interested in the way that we talk about mental health, the way that we stigmatize mental health, especially as physicians.
Great. Would you say that you've seen an influx of clinicians into your practice?
Absolutely. So I actually have opened up extra spots to see clinicians and staff right now. Part of what I've done as a frontline responder right now has been to respond in that way. So I shifted my practice from seeing more college students and graduate students to seeing more frontline staff. As a psychiatrist, I thought that was the best thing I could offer, which was like a good ear, a good skill set, and seeing my friends, family, and colleagues really starting to struggle and hearing the stories I was hearing, that seemed like the right thing to do. I have definitely seen people talking a lot more about the way that COVID's been impacting their lives. I've been hearing from colleagues about the unique ways that COVID has changed their workday, the way that COVID has changed their family interactions. Some people, because of being afraid of being sick, have not been staying at home, have been staying in hotels, have been staying away from their families, and that's their major support system. So there's a lot of change to people's lives. So even if they had psychiatric illness before, like they've had depression, they've had anxiety, it was under control. I've seen a lot of people coming back to us saying, I had this under control. It's not under control anymore. This is way worse for me, and I'm really struggling, and can you help?
Wow. Um, when you speak about mental health issues, there's obviously a wide range of things. And tell us a little bit about what you're seeing in healthcare providers, from little stuff to more major stuff.
Yeah, I mean, I think it's really hard because we use a lot of terms colloquially, and that's always been a hard thing in our field. So people talk about burnout, they talk about mental illness, they talk about depression, they talk about PTSD, and these words are used in the media, these words are used in headlines, and they're often used pretty incorrectly. So we're trying to kind of balance that and help people understand what's going on with them and what their symptoms mean. So what I always say is what you're feeling matters. So always start with that. So anything you're feeling is valid. And if you're feeling something that doesn't feel quote unquote normal to you, get help. So start there. So ask yourself what you're feeling, try to assess that, spend time with that at help with, like, as a healthcare provider, that's really hard to do because we're not very good at asking ourselves that question. But if there's no wrong time to get help, often we wait to get help when we're a little bit too far down the line. So if you feel like you need it or you might want to get it, try to get it earlier than later is what I always say. So start there. Then easy things to kind of keep track of are sleep, eating, and your day-to-day activities. So sleep, like, hard to manage often right now with COVID because our schedules have changed. And as healthcare providers, our schedules are often pretty bad for sleep, but you can keep track of things like typically I sleep this much and I'm not sleeping that much anymore. So keep track of that. Eating, we should still be eating. Again, as healthcare providers, shift work, things like that, it's really hard to eat normal meals, but try to keep track if you're eating less or eating significantly more, something to keep track of. And day to day life, like how are you interacting with other people? Are you still wanting to interact with your coworkers and your family? Are you not wanting to? Have you really been not wanting to go to work? Have you not been wanting to socialize, even though socializing again is really different? How does it interacting with and interfering with your day to day life is a big measurement we use too.
Okay, great. It's been my experience that many healthcare professionals tend to be self-reliant. They don't want to, they won't ask for help. They don't want help. How, what would you recommend for healthcare workers to recognize and balance their altruistic tendencies with the very real need to take care of themselves during this pandemic?
Yeah, it's a coping mechanism and it's also a defense mechanism. So it's a coping mechanism to be altruistic and it's also a defense to be altruistic. So, in the same time as we're saying, it helps me to help people. It also lets us not feel all of the things that we want to be not feeling to be helping people. So when I'm like that, or if I'm realizing that I'm doing a lot of things, like for me, I often am writing or I'm on social media and I'm trying to help people or I'm doing a lot of patient care. If I'm noticing that I'm throwing myself into that a lot, I'll check in with myself and I'll be like, am I doing this because I need to be doing this? Or am I doing this because I'm trying not to be doing something else or I'm trying not to be feeling something. So that's a really hard thing to be aware of. And defenses are unconscious for the most part. So it's really hard to be aware of them consciously. But I think we need to start checking in with ourselves and trying to notice, like, am I doing and doing and doing because I need to be or because I just can't be doing the other thing? And often with our work, we can't not do the work, but we can make time for ourselves even if it's hard. So I think there's always a bit of time we can carve out for ourselves in the day. We just don't like to ask for it. And I think we just need to ask for it.
Okay, great. I've seen in the press lately the term moral injury being used. Can you tell us a little bit about that and how does that play into the whole burnout mental health situation of providers?
Yeah, so moral injury is really used to, and when you're in this like distress that's caused by something that violates your moral code. So some kind of ethical belief system that you have. It doesn't mean that you necessarily did something. You could have witnessed something or you could have witnessed something not happen that would have been in line with your moral beliefs. It's not exactly mental illness per se, but it can lead to depression or PTSD. The term was really used in the military, but has been coming to light in a lot of ways in medicine right now because of it really started being talked about when we were talking about rationing care. So when we were talking about maybe we won't have enough ventilators, maybe we're not going to have enough medication, who's going to get this? That's not something we talk about very often in healthcare. So the idea that we would have two people and one person gets something that will save them and the other person would die is not morally what we went into medicine to do, right? So that's against our moral code. And having to make that decision or having to make that decision over and over and over is that idea of a moral injury. But even something as simple as like not having a mask, right? And going into work and knowing that my mask shouldn't be reworn because that's not what I was taught. And if I rewear my mask, I could actually be injuring my patients because I could be carrying COVID and therefore getting my patients sick. So doing something like that is also often against our moral code, and that can lead to anxiety. That can be traumatizing. That can lead to it can lead to depression. So I think that's what people are talking about when they talk about that.
Okay. I'm sure you're aware of, hit the news earlier this week about a physician in New York City who took her own life. Um, we'll never know the true story behind there, but there's been an issue with physician suicide for quite some time. Is the COVID pandemic, the tipping point, or what do you think's going on here?
Yeah. First, I'll say my thoughts are with her family and friends because it's a horrible story, and I don't know much about it. Obviously, none of us can know a lot about it, but I can say that. Um, I think as a person who's been interested in this field for a long time, we've had a problem for a long time and we need to change something. And if this is the thing that causes the change, I mean, I wouldn't have asked for a pandemic to be the reason, but I
Right.
think it does cause more of a look at the system and can cause change faster. And this kind of change needs monetary investment, it needs investment from the top, and it needs quick, like real systematic change, like big shakeup change. And often, like, that doesn't happen otherwise. We've had all of these conversations about burnout and depression in physicians for so long, and it's been mandated by our like education boards for so long. And often what we get are these like lectures on burnout. Nobody wants a lecture on burnout. They want to go to sleep. They want to
Mm,
go to sleep
yeah.
because that's how that helps with burnout, right?
Yeah.
But that's what we were getting. So that wasn't helpful. So now we have a chance to do right by our group and to figure out what that looks like. And I really, really hope that that's what we do.
Great. I know you're real connected in social media. What have you seen? What have you heard with regards to support programs around the country that perhaps hospitals or large practices are instituting to help out their physicians during and other clinicians during this very challenging time?
Yeah, I mean, I've been really impressed, frankly. I mean, I think as someone who's kind of watched this be something that's been an issue with very little movement for a while and seen how hard it is to get change in hospital systems, people have gone from zero to something pretty quickly. So that something has been this model of like putting in a hotline, putting where that physicians and other staff can call and say, I'm struggling, can you help me? That's often manned by somebody in the psychiatry department. That could be a psychiatrist, but it also could be anybody else in the mental health staff. I know that people also have been setting up like Zoom groups. That's what we've done, which is like, skills groups. So anxiety reduction groups, mindfulness groups, some support groups if you want them, some like crisis first aid kind of stuff. Which is really help, like psychological first aid, which is helpful for people, because knowing how to sort of cope in the moment might be all we can do right now. And that's a good skill to try to learn and be able to just show up for 30 minutes, learn a skill, implement it in your day-to-day life, and like see how that works and move on, right? And then I know a lot of places have also opened up more appointments. We're really trying to be more available to our staff and more responsive to our staff. And I think I've also seen that open across the country. So there are places like Project Parachute, which I know you'll show in the show notes, but that is giving pro bono therapy to frontline staff and opening, like you can ask for it nationwide and they can try to find you and pair you with someone who can see you pro bono. And that's great. I mean, that was organically started by someone who saw a need and said, like, let me help, right? And it's really kind of people, and it's generous, it's great to
Yeah.
see.
I'm going to encourage our viewers that if the place where you work or the place where you're employed has implemented anything that really is assisting providers, please share that in our chat discussion. Everybody here on the call would greatly appreciate that. You know, I'm not a healthcare worker at this point in my life. I was previously, but I am in the United States, and I'm sheltering in place and going a little bat crazy, little cabin fever. And I'm aware there've been some studies specifically about healthcare workers when quarantined during the SARS epidemic that showed some very interesting results. Do you want to tell us a little bit about those?
Yeah, I mean, it's so hard because people are like, what does that have to do with now? And when
Right.
we look at that stuff, it's hard, right? Because the SARS epidemic is actually quite different from what we're seeing because there weren't this many people and they weren't all self isolated and we didn't do it for this long. So it is kind of hard to apply, but we can try as best as we can. So when we look at those studies and we look at the studies from Ebola, what we can see is that being quarantined caused mental health problems, especially when you're quarantined for longer, and especially when like communication was confusing and it wasn't uniform, which, I mean, you can't say isn't happening, right? Like people change what they're saying daily. It's hard when you're a healthcare worker, especially, and you went to training and people taught you do XYZ and this is how you treat XYZ. But every day something's changing right now. Protocols are changing, treatment is changing. Like the way that we're doing something is changing. We're not people that change that quickly. It's just not the way we were taught. It's not the people that we are. We're kind of rigid. So that's anxiety provoking, right? So that makes sense. But if you look at those studies, healthcare workers were more prone to things like PTSD. They last
Mm,
for 3 years in some of the studies. I don't
wow.
know, like in the studies that they have, they didn't look longer, but I think from what I know about trauma, I see college kids and graduate students who have high rates of trauma from other things. And, trauma doesn't have a timeline. Like often people come in and they say, I'm not sleeping. And you start talking to them and you realize that something happened to them a really long time ago that they never dealt with. And that's actually affecting them now. And they had no idea that that was affecting them at all. So when I think about that, I always say, like, this could be something that we'll deal with acutely, but it's definitely something that we're going to be dealing with in the long term as a group. And I think it's important to think about that when we're planning, and to think about that in our friends and family, and to think about that when we think about how we help each other.
Okay. You mentioned a timeline, and that brought a question to mind. We're starting to see some of the cities, some of the locations throughout the U.S. starting to perhaps be over the hump, if you will, of the worst of it. Is there a correlation? Can people expect a correlation between their symptoms or severity of symptoms and where the prevalence of COVID is? Or is there a delayed effect? Is it a direct correlation, an inverse? Will these issues stick around for a long time? It kind of feeds into what you were saying just, right before this.
Yeah, super interesting question. And we have no idea. I mean,
Mm,
I think when I think about it, I think it would be so obvious to say, like, the places that have been hit the hardest by COVID will have the most trauma. Like, to me, that would make the most, like, tangible, logical sense, because they're seeing the most
right,
death, frankly, right? The
right.
hardest day to day. But being someone who lives in the Midwest and has also seen our hospitals prepare, and has heard kind of like, because of social media, because the world is very connected, because we have friends in healthcare all over the country, and because our healthcare systems like actively prepared for all of this stuff, which meant like telling us what it would be like to do a job we weren't trained in, telling us what it would be like to not have enough PPE, telling us what it would be like to
Mm,
put bodies in trucks, right? Like a lot of healthcare systems prepared for these things that are traumatizing just to prepare for.
right.
I think like that alone is going to have effects. Like there's an anticipatory like anxiety and grief that went with that. Maybe because it didn't live up to it, there's something else that goes with that. Then there's also like we're having pay cuts, and there's going to be lasting effects to healthcare because people weren't able to do their jobs that were their regular healthcare jobs because of COVID. And so I think we might have just like different effects in different groups because of that, right? So I don't know that we can say like it'll be really, I mean, interesting is such a horrible word to
Yeah.
use now, but that's the word that comes to my head. But like it will be, the breakdown will be there with different things for different reasons, I think. And I think that people will experience their own things for different reasons. And it might not be as clear cut as we think it will be.
Okay. Thank you for your thoughts on that. We do have a question from the audience. Since many of us are not healthcare workers, but work to support them through risk and legal issues, are there symptoms or behaviors that we as lay people can look for when working with providers to identify those providers who may be having issues? So what are the warning signs that our family and friends can look for in healthcare providers to provide some signal that maybe they need some help?
Yeah, so I'll give you basic warning signs, but I will also say that healthcare workers in general, and actually people in general, don't always exhibit warning signs. So
Mm,
people are pretty good at hiding things when they want to, and especially when they're just trying to kind of trudge through it and do their job. So you might not notice everything, but you always ask them how they're doing and listen and try to, give them the space to tell you. But I would say, again, sleep is a big thing. If they are really not sleeping, that's important. I think this, again, like if they're really irritable. So sometimes people, instead of like being anxious or sad, irritability can be how people take out anxiety or sadness. So like if they're kind of like angry a lot, it's not necessarily like they're just angry. It can be lack of sleep, it can be sadness, it can be
Mm,
anxiety. So that can be something sort of like moods that are unpredictable. Interacting in a way that's maybe not like them, like withdrawing from social things, withdrawing from interacting with you or other people, withdrawing from like maybe they were doing Zoom related social things and now they're not, or they just say, I can't do that. I don't have the energy for that. I just want to go like lie in bed and sleep. That
mm,
would be a warning sign to me. Alcohol use, big thing. So
big issue.
you can see this like on social media as like a kind of trendy thing where people are like, I'm just stressed, I'm going to go have a drink because it's quarantine and that's what we do, right? And some people can have a drink and it's fine, but it's not a quote unquote healthy coping mechanism, right? Like having a
Right.
tea would be a better coping mechanism. Going for a run would be a better coping mechanism. Going to sleep would be a better coping mechanism, right? So I think if like you notice that that's happening every night or more often, or the numbers of drinks are going up, that's also a warning sign. I think the way in which that conversation is brought up that's not in a blaming way is often helpful. I think like we often bring up things like, so you're drinking a lot, and that's not really helpful to people who are really struggling. But it can be like, I've noticed that when you come home at the end of the day, it seems like work's been really hard, and see if they notice on their own that they've been drinking, and
See,
kind of point them to the answer without pushing it in front of their face. And it's
right. Give
can
them that opportunity to share, if you will.
mhm.
Okay. Thank you. We got another question. How do institutions start providing strategies to develop more support groups for healthcare providers? And could huddles at the beginning of the end of a shift assist with the anxiety of COVID pressures? Is there sharing in huddle type? Is sharing in huddle type groups beneficial? So we got actually a couple questions here. How do institutions start providing strategies to develop more support groups for healthcare providers?
So that one, I would say you would try to find the people in your institution who would be best trained to do that. So for us, that was the psychiatry department, and we took that on. But sometimes that can be through like the employee access program, and they already have some trained therapists and trained like mindfulness people, and you could say like, listen, we have a need and we need more groups and this needs to expand like pronto, and they can do that because that's what they're supposed to be doing. They're supposed to be supporting the employees and including their mental health. So that's a easy place to start, honestly, is like starting to have the conversation with them. But you can also tell your psychiatry colleagues, or you can tell your mental health colleagues, or if there's a social work school, we've also been incorporating the social work school in the conversation because the students are not able to do their practicums, and there's a lot of
Mm,
students that really want to help, and there's a lot of people like that's a big resource for us. And so we've just been tapping people who really know what they're doing but have like just want to help, and that a lot of those people exist right now, so that's a good place to start, I think.
great, great. And what about huddles? Could huddles at the beginning and end of a shift assist with the anxiety of pressures related to COVID?
I think you have to follow some like psychological first aid principles. So I would look that up. It's hard to go into in a quick like 2-second thing. So Google psychological first aid. So like you just want to be careful not to like bring up all of the trauma at the beginning and the end of shift. But I think if you have like a conversation that's either like something good about the shift, something positive, like any sort of like good things that you can tell your team that they did that day, any sort of like way to lift them up, any sort of mindfulness break, honestly, or any like vulnerability from leadership is also really nice, because I think one of the things that people often don't see is that the person who's in charge of the team doesn't often say, like, this is hard for me too, or, I've noticed that like every time I've had to see patients like that, it's been a lot harder for me because of whatever. And I think then they just think that they're doing something wrong, or there must be something wrong with me because look at all these other people and they can handle this. They're not sad when they go home, and everybody's just kind of putting on a face that it's fine, right? And so there is a benefit to huddle in that way, which is like some degree of vulnerability, truth telling. You just have to be careful that you're not like opening up a bunch of trauma wounds and not being able to close them.
Yeah, so you talked about putting on that face, and yet healthcare providers oftentimes have to cope in the moment. How can they get that in hand? What specific advice do you have down, for in action right there? What can they do to deal with that?
Yeah, I mean, unfortunately, healthcare workers are pretty good at this, which is not
Thank
the
goodness.
skill set, but like I mean, I think that in the moment, the things that we can do are often like deep, like kind of like deep breathing skills, which you can don't take very long. You can do that in like 5 seconds and kind of center yourself, or any sort of like quick mindfulness thing to recenter yourself. So like often when people think about mindfulness, they think about like the Headspace app or some kind
Mm.
of meditation where they have to go to sleep and listen to someone talking. I don't even like those kind of things, but people do. And I tell patients to use it because it's really great when it
Mhm.
works. But the kind of things that I'm talking about are if you're feeling like super, super stressed out and your whole body is like reacting, like heartbeat going, like you're not able to think because your brain's kind of going a lot. You can do things like look around your room and name stuff. So like in my room right now, you can see like I have a purple couch, like I have a fireplace. You can just start naming things and it brings your brain to like now. And that's kind of important. Another thing you could do is like if you're a person who likes like a certain TV show or like cars, you can just start naming types of cars or types of
Mm.
like whatever kind of TV show. And it again just sort of like brings your brain from like being all kind of jumbled and out there and thinking about a million things, and sort of brings you back to the moment. And those are just like quick things and with the breathing that if you're really stressed you could do. I mean, I think like if you had time sometimes and you're more of a physical person, we would often say like run the stairs in the hospital for like
Mhm.
2 seconds.
Sure.
But sometimes that's harder for people. But I know like some people are much more physical than mental, and like would be a weighted blanket type or a stress ball type.
Mm.
And if you're a weighted blanket type or a stress putty or stress ball type and you have the time, run the stairs in the hospital for like 2 seconds and just kind of like get back to it if you can.
Great. Those are some great suggestions. And when we talked earlier, you provided a bunch of resources which we will post uh, on the chat session of this. Got another question for you from the audience. How can we support our non-frontline healthcare colleagues who have been working from home and self-isolating through crisis?
Like me, like people who are just doing telepsych all day.
Yeah, yeah.
I mean, I think it's really important. Thanks for asking, because they're definitely a group that we're not talking about as much. I think that checking in on them is important. I think that we don't check in on them enough. I think that there is a different kind of providing healthcare right now, and our jobs have also really shifted, and we're not doing what we're used to doing. So checking in is really nice. Um, I think that will go a long way. Honestly, you asking that question was surprising to me since nobody asked that question. So even just like asking it was a nice like realization that I should be recognized for doing something. So thank you. Um, I think the other way that you could support them would just be to like, encourage your friends to stay at home and follow the kind of things that like science is suggesting for healthcare, and like to flatten the curve and get this thing taken care of, because for the most part the kinds of things that we're taking care of in our telehealth visits are the kinds of things that we would be managing anyway, but they could get worse because maybe we're doing urgent care visits for COVID and they're just the
Right.
ones that aren't going to the ER. So keep in mind that those are the people doing those visits. Like, so anything you can do to encourage your friends and family or people on Facebook that might not necessarily agree with you, that are your friends and family, to still listen to science and prioritize science in the conversation.
Great. Thank you. We have one final question because we're running out of time. Any
Yeah.
thoughts on other first responders such as EMT, police? I have anecdotally noticed that there are extreme amounts of stress that could turn into PTSD and or depression.
100%. I mean, they're going to see the same stuff we are. I mean, I think they have very similar what they're seeing, what they do, how they function, how they put themselves before other people what they're expected to do. I mean, I think that those jobs are also going to need to prioritize mental health, and those like employers are going to need to do the same thing. And they're not used to it, and they need to. For the same reason, they run towards the fire. They are the first people on the scene. They are the first people helping in all of these things. Like, it's really important that mental health is not left out of the conversation, and that the only conversation is physical health. I'm a doctor first, obviously, but to me they're completely intimately linked. So we can't have a conversation about us not having PPE without having a conversation about what that does to us emotionally. We can't have a conversation about us not having testing without us having a conversation about what that does to us emotionally. We can't have a conversation about us opening up this country without us having a conversation about how we're supporting people. And we can't talk about healthcare workers without talking about what this is doing to their mental health. So I think it's like very clear to me that like they're another population that should be getting hazard pay, should be getting thought of as what they're doing for their mental health and what this is doing to their mental health. So again, all these people watching, thank you for being so thoughtful about all these groups that are often like not thought about. You guys are really great.
Dr. Gould, thank you so much for joining us today. That's all the time we have. We encourage you to follow MedIQ on any or all of our social media platforms such as Facebook, Twitter, LinkedIn, or Instagram to hear about all the clinical risk management and patient education that we have to offer, available in many formats, including more COVID-19 and telemedicine related content coming soon. Thanks a lot for joining us. Keep washing your hands and have a great day.
Thanks.
Thank you.